Welcome back to the Sports Talks podcast. I'm Dr. Ashley Bassett.
And I'm Dr. Catherine Logan.
On each episode, we chat about the most recent developments in sports medicine with experts from around the country. In this episode, we're going to continue our discussion with Dr. Rachel Frank and focus on emergency action plans, as well as the sideline management of some common soccer-related orthopedic injuries.
Our conversation picks back up with a review article published in the July 2023 issue of Clinics in Sports Medicine titled On-Field Sports Emergencies, Preparation and Readiness. Authored by our guest today, this paper discusses the importance of an emergency action plan. The emergency action plan should include site-specific implementation, personnel who are involved, equipment, communication, transportation, and location of emergency care facilities. This paper notes that improvements should be made following self-evaluation after each on-field emergency to ensure the EAP is optimal.
Then, from the upcoming issue of the Yellow Journal next month, we review an article titled Management of Sideline Medical Emergencies. While most sports-related injuries are benign, the potential for catastrophic injury is omnipresent, and covering team physicians must be prepared. This paper nicely highlights the acute management of a variety of medical emergencies, including cardiac arrest, respiratory failure, nervous system injury, significant bleeding, abdominal trauma, and specific musculoskeletal injuries, including hip and knee dislocations. The authors point out that physicians must be comfortable recognizing the signs and symptoms of life-threatening emergencies and not hesitate to rapidly escalate care and initiate an emergency response.
If you're looking for a trusted name in allograft transplantation and want to learn more about allograft options, then look no further than JRF Ortho. JRF Ortho is the innovative leader providing the widest array of pre-sutured tendons, including the only BTB pre-sutured tendon on the market. Plus, they were the first to offer OCA cores, available in 10mm, 12mm, and 16mm sizes for small focal osteochondral defects. JRF Ortho also prides itself on superior customer care, making your ordering process JRF Ortho easy. They are committed to accommodating your needs, usually delivering osteochondral allografts around 30 days, all on your terms. So, if you are tired of waiting for weeks for a condyle or waiting on a back-ordered tendon, reach out to JRF Ortho to find out how you can get your allografts in a timely manner. And the most amazing thing is that JRF Ortho aims to give you one less thing to think about, so you can focus on what matters most, your patients. So, discover the only allograft company solely focused on sports medicine. Order your allografts with JRF Ortho today.
So we're going to shift our discussion now to emergency action plans. So in January of last year, the country watched as Damar Hamlin collapsed onto the field during Monday Night Football in cardiac arrest. And in the soccer community, a similar event happened with Denmark player Christian Eriksen. And both these athletes were saved due to the quick actions of their medical staff members, which draws attention to the importance of having a clear, but even more importantly, well-practiced emergency action plan. So Rachel, how does your medical staff prepare each year to deal with these critical emergencies that can arise? Who joins the EAP practice session? You kind of mentioned this a little bit on our first part, but can you dive into this a little bit more for us?
Yeah, such a good topic, and kudos to both of those organizations' entire medical teams and the EMS who are covering the games, the visiting teams, healthcare systems that we're helping out. Just a perfect example of when you're prepared, how outcomes can be impacted positively. So this has been an interesting time, especially with those two very well publicized cardiac events that, again, had good outcomes, but due to quick reactions. And we have a system for the Rapids. We have a system for CU athletics. And then when I've been with US Soccer, everything kind of changes if you're home or on the road, and on the road can be in a different country with protocols that you're not familiar with. So having an EAP is critical. The way it typically starts is we have a document. So a document that is for this venue. We play at Dick's Sporting Goods Park in Colorado for the Rapids. This is our emergency action plan, and we have it written, and then we edit it every year. in preseason, we meet as a team with a huge group. So we bring in the EMS team that typically covers the game, and we have anywhere from 2 to 6 EMTs and EMS specialists that are there during the games, and they kind of rotate throughout the season. So we get to know them on a first name basis, and we get a feel for what their skill sets are, and they're phenomenal. And I'll go through kind of what we talk about at those meetings, but the EMS teams included, all of the primary care attendings, all of the sports medicine ortho attendings who will be helping cover the team come to this. So it's logistically a nightmare, but we get it coordinated. Mm-hmm. The athletic trainers, head athletic trainer, assistant athletic trainers, anyone who might be working regularly on a stretcher crew, anyone else from the team from sports science or strength and conditioning or coaching staff that wants to be there. So that's kind of the crew. And then we bring in all of our fellows. We're very lucky to have sports medicine fellows. So we bring in both the non-surgical and surgical sports medicine fellows because they'll be covering the games with us. And we do this for the Rapids, but we do this for every one of the pro teams that we cover at CU. We do this for the CU Buffs, and we do this for the high schools that we cover at the beginning of the season. At that first meeting, we say during games, this is what the plan will be. And then we go through spine boarding and how we want to manage spine boarding. And there's a lot of different ways to do that. And it's a little different in American football versus soccer just because of helmets. But we talk about how we manage all of that. Then we act out different scenarios. Athlete is knocked out face down. Athlete's knocked out face down, not breathing, et cetera, et cetera. Mm-hmm. And we actually act those out and do the spine boarding and make sure that we are comfortable. And everyone does it. It's not corny. Everyone does it. Everyone gets down and becomes the victim. Everyone has a turn at the head. Everyone has a turn lifting the spine board, et cetera. Then we go through EMT, EMS protocols. If we're going to have a cardiac event, what kind of meds do we have? Who's putting AED? Where? What is our process? So we do this all at the beginning of the season, and that's great. And it's a good refresher, especially for our fellows. But the most important part for me is the before game meeting. And we do this before every game. So this is when we come in, we do this during warm-ups, referees, stretcher crew, EMS, both teams, medical teams, whoever they've brought, athletic trainers. And typically, if we're at home, our athletic trainer will lead this, and everyone introduces themselves by first name and their role. And then we say, hospital is 7 to 10 minutes away. Level 1 for spine, trauma, and everything else. And we have contacted the people on call so that we can get in easy if need be. 1 to 2 of your team members can ride along with an athlete if you wish. Otherwise, we can send someone with. So we talk about EMS. We then talk about hand signals. So we have different signals that are pretty commonplace in the MLS. Fist in the air to mean one thing. We waving our finger in the air means let's get the ambulance on the field. We talk about where the ambulance will come from and then where the backup ambulance will come to once the first ambulance leaves. We talk about if there's a cardiac emergency, who's running the show. And typically it's EMS, but the primary care doc has the ability to also run the show if they want. So we make that decision at the beginning during this EAP meeting so that there's no confusion if this were to happen. We then talk about, okay, typically for us, we agree that we'll do 2 to 3 rounds of CPR on the field, and then we try to get them on the stretcher and into the bus and off. And so we have a plan in terms of, so no one's really wondering what's going to happen and how long is this going to take. We talk about what facilities we have in the facility. We don't have x-ray, we have ultrasound, we have suture kits, lacerations, what meds we have, et cetera. We confirm who's going to manage the AED for both teams because there's typically 3 AEDs, the ones EMS has, the one that we have, and the one that the visiting team has. So who's running the show if we need an AED? You guys know, and everyone hopefully knows, that's the most important part to cardiac recovery. So we need to know who's doing what. It can be chaotic. And so we go through all that, and then we ask if anyone has any questions. We talk about our concussion protocol, which we highlighted earlier, and how the VMD has to make that final call. No questions, ifs, ands, or buts. And then we go from there. And when COVID was here, we had to talk about COVID protocols. We don't really have to talk about that anymore, although probably we should. And so that's how we do it for the Rapids. When I travel with US Soccer or we're away, I like to get a document ahead of time. What does the field look like? What's the venue look like? Where's the nearest hospital? What language barriers are in place? What context do we have with their physicians? How can I get in touch with someone if I need someone? Where can I get imaging if I need something? And it can be going away, especially with a language barrier, can be challenging. But we try to have those EAP meetings before every game at the warm up.
That's great.
Yeah, I think, there's so much. I think the thing I always think about when I'm on the road is there's so much that can go wrong. You know what I
Yes.
mean? Like, so it's like, it's almost like surgery where you're sort of like, okay, what are all the things that if something goes wrong, what do we do or whatever? And so all of that stuff, it's like reviewing your timeout of just like,
Totally.
before surgery. And, I think it's even at the high school level, all of that data and all that information, talking to the refs, talking to the coaches, knowing where the ambulance is. It's like so important to like walk over, shake their hand, introduce yourself, like, have all those sort of like pre-game sort of meetings. And for US ski and snowboard, sometimes we're overseas and they really prepare us with so much information and just remind us all the time, because we're a lot of times plugging and playing of like, okay, now you're in this country or whatever. And they'll say, don't forget to download this app. This app is going to help you translate, or you know what I mean? Or just make sure you have this in your kit. And sometimes you have to helicopter out and you're like, what? Like,
Yes.
but they have to prepare. They do an excellent job preparing, but all those details, I mean, if you don't have them in place, there's so many things that can go wrong. But you guys obviously have it very well dialed. But I think it's like those little things that's like, even though you have a team around you, it's just like ultimately, like you have a ton of responsibility when you're on the sideline, and you really have to always be, I'm ready for like the worst case scenario.
I think it's why it's so important. I tell our fellows this, we're scanning the field the whole time. You're looking for stuff that no one else is looking for.
Yeah.
And it's not scoring of a goal or scoring of points or a touchdown. You're looking for everything else. And you can't be a spectator. You have to be an observer. Yeah. And it is truly a matter of life and death sometimes. Totally. I mean, at this point in our surgical careers, most things should be very comfortable, and you've got plan A, just like you're mentioning, but B, C, D, and E are in the back of your head if something happens and that it doesn't go according to textbook, which can sometimes happen in surgery. You don't have the luxury of that time when it's life and death on the field. And again, I sound dramatic right now, but we've seen it, and you really do have to make some decisions. And so that know before you go mantra, being prepared, as corny as it is and as repetitive as it gets, especially if you have multiple games a week, it's just so necessary, because there's new faces, there's new crews, or even if it's the same crew and you're like, all right, we just did this 3 days ago. This is what we're doing today. This is, and you go through everything. Not that I would ever wish any problem to any athlete like what we've seen with the two that you highlighted, but I do think it's raised awareness that this is acceptable even down to the high school level and needs to be done. So I think, we would never wish those injuries, those cardiac complications on anyone, and so thankful that they've both have had a great outcome, because unfortunately lots of people don't. But I am thankful that the good that's come out of that has raised awareness about how important being prepared is.
Yeah, no, I think you're totally spot on. And like, it just, it's all fortunate it went in the right direction. But I do think there's a lot more acceptance now when you arrive at a field and they're like, yep, what do we need? What can we do to be prepared? And, just the reality that these things can happen.
Totally.
Yeah, absolutely. Yeah, so you talked a lot there about kind of cardiac emergencies, because obviously, that's the one that everyone worries about now. But we do want to touch a little bit just on C-spine injuries. So I know you primarily cover soccer, but you also cover, University of Colorado. So you cover sports that'll have equipment on them. So in addition to talking through kind of the emergency approach to someone with suspected C-spine injury, I want to ask actually you both, because Catherine, you cover lacrosse, that has a lot of equipment. I cover a lot of football here in New Jersey. Protocol in terms of equipment removal versus packaging, sending, removal at hospital. It's always a hot topic that gets brought up at our EAP meeting every year. People have very strong opinions one way or the other, and I make sure we come up with a firm protocol moving forward, and we discuss it at the start of every game. But I'm really curious to hear what you guys think. So Rachel, why don't we start with you?
Yeah, what a hot topic. And I think no matter what I say right now, I'm going to offend someone, whether it's the NATA or primary care docs. I'm about to offend someone. So I apologize in advance. This is a hot topic in terms of, first and foremost, you need to have a plan for spine boarding. Are you doing a 7-man lift or 9 or 4? Like, how many people do you have available? Sometimes at the high school level, you've got no one. So who's going to help you with that? Who's going to be at the head? Who's going to be giving orders, et cetera. So you have to have roles all defined out. and then hopefully you've practiced how to spine board someone. In terms of helmet on, helmet off, we typically leave the helmet on. And then the biggest question is face mask. And certain athletic trainers for decades have wanted to keep the mask on. Others have wanted to clip it off. If there's a cardiopulmonary issue, we typically do need to try to get access to the patient's airway. And so mask would come off in those cases. But if we're not concerned about that, our protocol has typically been to leave everything on and package with a good spine board and good C-collar and good support. But there, and you guys correct me if you have different protocols or what you're thinking, but I don't know that we have any consensus yet in 2024 about helmet on, or mask on, mask off with hockey face masks and football face masks. But I think the general consensus is helmet stays on unless there's a crazy good reason to take it off, which I can't think of one off the top of my head.
Yeah. And I don't cover much hockey, so I'm not sure what they're doing in hockey these days either, but lacrosse, very similar, like, Rachel, to you, that we just, package them up and get them ready. And, I always think, like, you said in the beginning of the season, you sort of practice things, you make sure yourself, the patient or the athlete, all those sort of things of having that lined up beforehand is really the most important thing. And like just establishing like who's the leader and who is, because all of a sudden you realize that certain people get very nervous in those types of situations. And there could be a lot of volume and a lot of like cross talking and stuff. So I think, regardless of what you do with the helmet, because there's different beliefs, it's establishing that leader, of who is going to be running the show and who is the voice that we should be listening to is, the most important thing. Like one of the things that happened when I was covering a lacrosse game once was, we did have a C-spine injury. And so we were getting them ready. And as I'm sort of at the athlete, I feel a hand come like next to me, and it's a family member. And someone come from the stands, and security didn't keep them away. And it was just one of those things that I was like, okay, I'm just going to stay calm. And this is not okay. But, but
that's terrible.
It's like, you just have to be prepared, right? And this was like in a professional stadium, and they had jumped the fence and gotten through, and no one thought to say, hey, family members, stay back. So I always feel like no matter what you do, you just have to establish who's in charge, and that person needs to just be relaxed, and concerned.
I think that's a really good point. And I think that's, again, draws attention to practicing the EAP, because when we went through it, they were like, we want the doc at the head, but like also the person you want at the head is someone who knows the athlete, like they're comforting the athlete, they're talking them through. So then what we ultimately decided on is that the doc would be on the side for, in cases of cardiac arrest, because they're going to start the CPR, and the AT was going to be at the head for potential spine injuries, even, and make sure that they're comfortable with the spine, mobilization. It's interesting to hear you guys both talk about keeping on the equipment, because actually we came to a different kind of consensus at ours. So for JV, as Rachel alluded to, they have one person to spine board. So they can't do this 7-man lift. They can't do this whole, like, the equipment staying on, because they can't hold the neck and remove the equipment at the same time. That's going to be bad. So they're bundling them up. They're calling for EMS, because JV games, they don't have an ambulance there, right? And then they're sending them to the hospital. But for us, our local hospitals, even though they're level 1 trauma centers, they hate receiving people with equipment on. And honestly, I don't think that they're very well versed in removing it. And of course, if the game's coming to an end, I'm leaving with that athlete. And if it's a catastrophic C-spine injury, I'm leaving with the athlete, right? But if it's going to keep going, I can't leave. Legally, I have to stay there. So, and we're not going to send the AT. So it's one of those things where we felt for varsity games, it was actually more appropriate to remove things. And in that case, you're removing everything, right? Because if you remove the helmet, you have to remove the pad. So we practiced that, and that's our game plan, and EMS was on board with that. But again, very controversial, right? We had some established ATs that were just like, I don't think this is a good idea. I think we put the blocks and we send them, but I think it kind of won out. Removing everything, if you have enough people to safely do so, was ultimately where we landed.
So much of this is resource dependent. I mean, you're going to be at an NFL game where you've got a bajillion people to help, and it never feels like enough. And then you'll be at a high school game where you won't have enough to do it. Even if what you think is right, you just don't have the resources So I think that communication though with your hospital, knowing their strengths and weaknesses, if no one's going to be able to travel, they're not familiar with the devices needed to get the mask off, to get the helmet off. How do football pads work? A lot of people have never played football and they don't know how football pads work and how these athletes are actually strapped in with their padding. So I think the communication is key, and working within the resource constraints that you have or don't have is really paramount. So yeah, and then there's bias and historic ways of doing things. And we all have that. I have bias with what I think is best for X, Y, and Z. And so managing all of that, communicating all that, and making sure that when it happens, you're not thinking and deciding, you're just executing. All of the decision making has already happened. So that, I think that's the key to all of this.
Yeah, absolutely.
I think that's a great point. And I think, it's just like anything. It's like that communication and establishing the plan piece. It's like, as long as everyone's on the same page, you're probably going to get the same end result.
Exactly. Awesome.
Go ahead, Ash. What were you going to say?
Oh, no. I was going to shift us away from emergency cardiac and C-spine to orthopedic stuff. So we can talk about more fun things now.
Let's get it.
Emergencies, but more fun things. So I'm going to hit you with another controversial one, which is, dislocations. Do you reduce them on the field in front of the bright lights, or do you get them off the field? And I was going to start actually with, let's start with hip and knee. Let's start with lower extremity ones, right? So Rachel, what's your approach? Cameras on, they haven't cut away. Are you attempting one? Are you getting them into a place away from cameras? What are your thoughts on that?
So very situationally dependent. My preference is if I can get them off the field and get them into the locker room, especially if we have X-ray capability, I prefer to do that. There are some instances where that cannot be done. And so the summary statement is, if I can get them off and do it away, I'd rather do that. That's why in the NFL they have the blue tent, et cetera. We'd rather do that. That's not always practical. So for lower extremity, if there's a gross deformity, like a long bone fracture, we're trying to get that stabilized. EMS comes out. There are splints that will splint on the pitch. So we try to do that. If it's a true joint dislocation that you're thinking is dislocated, for example, a hip, I'm not going to try to pull that on the field. First and foremost, a lot of these athletes are a little bit bigger and we need traction, counter traction. If it's a knee that's clearly dislocated, you're worried about a vascular injury, something like that, I think you can give a pull and try to get that leg out to length and hold it, but it's risky. If there's a fracture, you don't know what's going on. I think doing anything on the field without diagnostics can be risky. Yeah. If it's an ankle and it's like there's a gross subtalar dislocation or gross ankle dislocation, I think you can try to reduce that on the field if you can get access to the athlete's ankle. But again, my preference is to get them off and get them in a more controlled environment. So that's lower extremity. I have had some upper extremity situations where the athlete is, especially in soccer, where they don't necessarily use their upper extremities as much if they're a field player, but they dislocate something and they want you to put it right back so they can get right back out on the field. Yeah. And sometimes we're able to successfully accomplish that if we feel that the diagnosis is pretty clear and the reduction maneuver is pretty clear. But my preference and my take-home point, and if there's any young team physicians listening, I think the instruction would be try to get them off the field into the locker room and do it in a controlled setting.
Yeah, it is really funny. Like lacrosse has a ton of shoulder dislocations, and there's some of them that like you can't even get near them because they're like, this happens all the time, I'm good. And they just like,
oh they do it. Yes. Yes.
Like, oh God, like would you?
Yes.
So they're just like, I'm fine. That happens all the time. And they worry you a little bit because you're like, can we image the inside of your shoulder? And they're just like, no,
they want to go right back. Yeah. They don't want to know. They've put it back themselves, or you've kind of hold it and they'll help you a little bit. And we've had this as well. And then you're like, do you have a fracture? Do you have something that if you fall again, you're about to make this worse? And so again, we try to get them off the field, and if they've dislocated something, that's usually an indication to me that they're not coming back onto the field. The one exception in soccer for me is if they're a field player and it's a finger and we can get it back, I'm willing to let them. And again, we've let some shoulders come back. It always makes me a little antsy when we do that. But yeah, typically if there's some sort of joint that's out of place, or certainly a fracture that's obvious, they're obviously not coming back, and we'd like to take care of that in a controlled setting. We have had open fractures, and those are always a little tricky, especially on the tibia, because there's the socks and the shin guards and it's dirty. And so again, I like to wash those out before we're kind of reducing things. And so if we can get them back in the locker room to do that, let alone to the emergency room, that's ideal. So I think this is one of those things, you can be out, we're in Colorado, you could be out hiking and fall and dislocate. You'd want someone to reduce your ankle right then and there. You wouldn't want to wait to get down the mountain or wait for someone to cart you off. If something's grossly off and they're in a ton of pain and you're right on the field, I think you can give it a go. But for the vast majority, those are so infrequent. For the vast majority, I think you try to get them off.
And Rachel, something you really highlighted there about in terms of getting them off into a controlled environment so you can assess them, right? And it may not be X-ray that we have. You mentioned sometimes you just have ultrasound. And if you're covering, high school or D3 college, you're probably going to have nothing there, right?
Yeah.
I think a lot of times there's a lot of I've assessed so many players on the field that tell me it's dislocated. I'm feeling, and I'm like, their shoulder's not dislocated. What are you talking? They're panicking, right? And you examine, it's like it's an type 1 AC, right? And it's like, I'm not poo-pooing their symptoms, but everyone's up here, and then the coach is like, pull on the arm, and then the AT is starting to yank on the arm, and I'm like, everyone take a breath, right? If you get them off the field, you sit them down, you take off their helmet, you have them take a breath, you feel, and you go, everything's okay. Let's put some ice on this. It's okay. I think in the heat of the moment, as you said, you can make some erroneous decisions if you don't take time to assess it away from the lights and away from all the people surrounding the situation. So I think that's a very good point. Yeah.
Well, I think in today's medical legal environment as well, number one, you always want to do what's best for the athlete. And if you're in a more public scenario where it's on TV or going to be streamed and everyone is on YouTube and capturing stuff on their phone and all that, you always want to do what's best for the athlete. You want to make sure that you're not feeling those extra pressures to make a reduction that doesn't need to be done simply because you're being watched or pressured. So I think as you're spot on, there's a lot of people who think they know best. And this is where, again, having that plan ahead of the game, you being, as an orthopod, this is in our wheelhouse, but I'm a sports surgeon. I'm not a foot and ankle surgeon. I'm not a trauma surgeon. So I don't see this stuff every single day. And so you want to make sure you have in your mindset, this is what I'm going to do for this injury. This is how I'm going to attack this. This is my preferred way. If that doesn't go according to plan, this is my backup plan, et cetera, et cetera. And trying to let the noise be just that, be just noise. I mean, I remember when I was very early in practice, I was covering a high school. I won't say what area just to not implicate anyone, but we had an injury on a star athlete, and the parent wanted that injury fixed right then and there on the field. And that was not something I was comfortable doing. I don't think any doc would be comfortable doing that. And we had the athlete's parents come down and make some verbal threats about my abilities and what they preferred in terms of the action plan. And you've got to be confident. And at the end of the day, the only thing that matters is the athlete in front of you, right? That's their safety, their health, and their ability to survive that injury and hopefully get back to playing at some point. So I think, again, for seasoned docs, this hopefully, this is nothing new, but for maybe some of the younger listeners, this is, it's really easy to get swayed by the pressure. And so I think just remembering the athlete in front of you is the most important thing. The noise is just noise.
No, I think that's an excellent point to end on. And because it's so true. It's just like, there's all these people in your ear, on the sideline, whether it's like the coach or you actually hear a family member or a parent or like just the other athletes, it's sort of helping them a little bit. And you're like, we don't need that right now.
Yes.
Back up.
Yes.
So I think that's super, super helpful. But you may or may not know, we always end our episodes with something called the Fast Five, where we ask you 5 quick questions about it's like OR preferences, because people actually like to know what you, a little bit about you.
Sure.
So they're super, super easy questions. You will definitely know the answer. So
okay, perfect. Here we go.
Okay. So in the OR, do you prefer foot pedal or hand control?
This is a double answer. Foot pedal for shaver, hand control for the radio frequency, so that it's just one thing on the floor and one thing in my hand.
Yeah.
Me too. Nice. Shoes in the OR.
Tall, black, waterproof boots. The cheapest ones I can find because I go through them like crazy.
Yeah.
All right. What is your favorite OR lounge snack?
Oh, well, we are very fortunate to have generic graham crackers and sometimes name brand peanut butter. So when we get the name brand peanut butter, I'm in business. When we get the generic peanut butter, I'm sure you have experienced this. It's a little oily, less delicious. But yeah, the graham cracker peanut butter snack is what I go to.
Awesome. I'm really excited to hear your answer on this one because I need a new station. What music do you play in the OR?
Almost. So, well, if we have a rotating student, resident fellow, I let them pick so I can get a feel for what we're doing, except heavy metal. I don't allow that. If I always ask the patient, what's your preference? And as they're going to sleep, we'll listen to what they want. And if it's something I can tolerate, we'll listen to that during the case. But if I get to pick, I try to let others pick. I'm usually listening to Kygo or Chainsmokers, something EDM. And then if it's going to be a stressful case, because we have those, on occasion, I actually like a little reggae. I like to get the vibes going a little smooth, a little, Bob Marley, a little reggae, and everyone just relaxes a little bit. So that's my vibe for a more stressful case.
Yeah, we do the same thing when someone, my athletic trainer, she calls herself, she says she's like the vibe master. She's like, when the patient is like about to go to sleep, she asks them, what song do you want to go to sleep to or whatever. And it's like, you learn new bands, you learn, whatever. Yeah. But we had this guy recently who's like a young guy and he asked to play Michael Jackson Thriller. And I was like, and so we kept Michael Jackson on the whole time.
That's a phenomenal OR playlist. Michael Jackson would be great because there's so much variety with his music. That's great.
So, but sometimes you're like, oh, I would have thought of that. But okay, last question of the Fast Five. What is your favorite surgery? You have to pick one.
Osteochondral allograft transplantation. I can do it all day, every day. That's one of the. I mean, that is one of the procedures that influenced me to become an orthopod, and you give the gift of life to someone else who's going to use that gift of life. So it's such an elegant, amazing procedure. And when it goes well, it goes great.
It is. Yeah. It's very satisfying.
Yeah, absolutely.
Cool.
Awesome. Well, thank you so much for taking the time to join us tonight. This was great, really helpful.
Yeah.
I can't wait to send this to all the ATs and the schools that we covered because I feel like it'll be a good synopsis of our EAP meeting we just did. So thank you so much. This was awesome.
Yeah.
Well, thank you both for having me, and thank you for doing what you do. I think two incredibly powerful, strong, talented women in orthopedics, sports medicine, really pioneering so many good topics for all of us. So thank you both for doing what you do, and this podcast is amazing. And again, thanks for having me.
Thank you.
Thank you.
All right, Rachel, have a great night, and thanks again.
All right, thank you guys. Take care.
Thank you for listening to this episode of the Sports Docs. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or a comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod and Twitter at thesportsdocpod. We love your feedback.